Miss Voss. Hello, everyone. I'm Darlene Torres Voss, and I'm one of the consultants for Harmony Health. Today, you see here our presentation. I'm really excited. We have a lot of information to share, hoping we'll get through all of it. Um, I want to just start by asking you all if in the chat box, just, there's engagement, you're more than welcome to please share your name, the agency you work for, and one of the social determinants of health codes or items that you feel like you see the most regularly at your agency. And then I'll let Esmeralda introduce herself.
Happy Friday, everyone. My name is Esmeralda Aguilera, and I am also I'm an LCSW and specialize in case management services. And I am here as a consultant as well, kind of creating these learning circles for you all through Harmony Health. So I'm happy to see everyone here.
So today we're going to go deeper into the why for SDOH matters for care planning and how we translate screening results into a strong care plan using SMART goals and the golden thread documentation that you've heard in some of our previous presentations. This session is designed specifically for ECM and case management roles, and everything we'll cover today ties directly with the daily workflows and documentation requirements. Next slide, please. We'll walk through how to define SDOH and how it affects health outcomes. You'll learn how to validate SDOH tools in a way that supports assessment, risk stratification, and care plans. We'll align screening results with the correct ICD-10Z codes, which is very important for medical necessity and, of course, when being audited. Then we'll turn those needs into SMART goals and care planning that match interventions. And finally, strengthen documentation using the golden thread that ties everything together. So assessment, need, goal, intervention, and progress. Next slide, please. Thank you, Zoe. This session builds on your prior training that we've done around assessments and care planning. You already know what ECM clients need, obviously. You're doing the work. Now we need to focus on the drivers behind those needs. Today we'll highlight your role as a bridge builder, connecting SDOH needs to concrete measurable outcomes. Next slide, please. Thank you. What are social drivers of health? SDOH, the social drivers of health that's been called, social determinants of health. It depends on what term is, being utilized at the state level, but we all obviously know what it means. And I don't necessarily want to read the definition. It is here for you to access. But what I do want to emphasize really is this idea of health-related social needs and what that means. So you'll hear the term HRSN, and it really refers to the individualized manifestation of the SDOH. So social determinants of health is a food insecurity, but how is it individualized for that patient or that family is going to be something that we'll kind of dive a little deeper into. And then case managers see this every day. So, poor medication management, homelessness, missed appointments, transportation support or anxiety, and then really financial strain. So one of the things that we're doing is really identifying how to individualize that SDOH need. And one of the things that we're seeing in the research is that 55% of overall health outcomes are the reason why it's important to have ECM case management. It really supports, again, addressing the barrier and just addressing the individual. Next slide, please. All right. In ECM and community supports, SDOH is not optional. It is a requirement to your comprehensive assessment. SDOH findings shape acuity, risk, care plan priorities, and what interventions you will deliver. Think of SDOH screening as your map. It tells you what barriers are keeping the client from reaching their health goals. And again, here, the slide really shows, the SDOH versus the individualized level that's identified through screening. Next slide, please. All right. So SDOH, conditions influencing outcomes, right? Many times we're seeing housing instability, we're seeing food insecurity, transportation, unsafe living situations. And these are services that are available maybe through our own agencies or that we have a really good partnership with our community in order to support and address this matter. I want to also say that when SDOH needs are unmet, chronic case management becomes much harder for us as the case manager. Patients often struggle to manage their medications, attend follow-up meetings, and staying engaged with things such as mental health or substance abuse treatment, or really just making sure that they're addressing that chronic condition. This also, when unaddressed, also leads to becoming high utilizers of the emergency room. And so it's important for us to make sure that we're addressing these barriers and helping our community understand the difference between attending medical care and then also utilizing the ER as their primary care. As well as I wanted to talk a little bit about the CalAIM and how they recognize SDOH as an essential part of a whole person care. And that's why it's also important for us to make sure that we're supporting this. ECM requires us to assess, document, and integrate social determinants of health into our comprehensive case plans. This ensures that interventions are tailored, referrals are appropriate, and that outcomes are measurable. Next slide, please. All right. So screening tools, we talked a little bit about them at some of our previous meetings, but these tools, the HRSN, the Prepare, and some of our local county forms are normally what are utilized for our screening tools. We screen at intake, we reassess, and anytime a circumstance, requires it, if there's a change in their life experiences or in their concerns, those are times when we have to identify and rescreen our patient or our community. Documentation must always include the date, the tool that was used, the domains that were assessed. We want to also make sure that there's some client self-reporting that happens there and any scores that were documented during the screening tool. And this is what creates that thread that supports the Z codes and the care plan entries that we've been talking about. Next slide. All right. So this is a big one, and I know we talked about it previously, but we always want to make sure that we're using protective language and not deficit language when we're addressing the client's needs and discussing the client's circumstance in our case notes. So describe the barrier, not the personal failure. Always include the specific need, the impact on health, the client's voice, and the risk if unaddressed. And an example I have here for you all is the client reports food insecurity that impacts their ability to maintain diabetes management. States, I skip meals so that I can pay for rent. It's very clear, the areas that you're going to support, and it's there in a way that does not address a non-deficit and also not utilizing protective language. Next slide, please. All right. So we all know these Z codes, I'm sure. But these Z codes are essential to the link to address the health and the outcomes, right? And they are required for ECM to demonstrate medical necessity, risk level, and the justification for case management involvement. Proper use of Z codes helps to avoid audit findings, like no evidence supporting the code is something that we'll hear if it's not documented properly. So the Z code just reinforces the interventions that are tied to the care plan. Next slide. All right. I haven't had an opportunity, maybe Esmeralda wants to share, to kind of look at the thread to see what Z codes we're seeing commonly. Okay, thank you. But these are some of the ones that we see. We see, the Z59, homelessness, food insecurity, the inability to pay for utilities, occupational exposure challenges. So working in the fields, seeing that maybe there's some struggles because they may be pregnant, and also, not getting enough breaks for the restroom, maybe social isolation. Low literacy is a really big one with our community. And then, of course, family stressors. I want to also talk a little bit. I want to be conscious of our time, but I also wanted to talk about, an example here. An example here is, the Z59.4, food insecurity. I think that one of the things that we also address here is there's so many opportunities, especially with CalAIM, to support someone who's maybe diabetic and wanting to be a part of a prescription food box, as well as getting some of the diabetic needs met through other resources, such as a food distribution site, or for isolation. What kinds of ways can we support them, the individual, becoming more involved in the community, something that maybe meets them where they're at that moment, while still having plans for future kind of ways of supporting. And I'm going to say next slide because there's a lot that I can cover in this, but I really want to get to some of the other slides and share some of that information with all of you.
Thank you, Darlene, for all that information. And the slides will be shared with everyone. And I did see on the chat, there are common ones that we did point out: food insecurity, housing stability, the social isolation one. I think it's sometimes that some people don't recognize that is something that does impact mental health and the well-being. So really addressing those is really important. One of the things is Darlene has done a great job in just kind of explaining to us what SDOH service, what they are, how they're implemented, how we need them for medical necessity. That's great. And we identified doing the comprehensive assessment, but how do we interpret that and create them into measurable medical necessity within our care plans? So, we got to consider weak statements don't communicate the risk or the medical necessity. Clients needs help with housing. That's something that is a statement, but it doesn't give us the information. It doesn't give us the medical necessity that is needed when we start documenting and creating these care plans. Strong statements, we want to identify the need, the impact on the health, the risk. And most importantly, we want the client's voice. We want to make sure that whatever it is that we are supporting, that we are acknowledging what they are saying is a priority. In regards to their SDOH, some of you have your clients and you do understand that there are so many needs, so many challenges, so many barriers that in order to really support them, we really do need to kind of consider what is the specific priority for that specific client to meet those needs that they are identifying for you. So what do? We need to create these into SMART goals because that's what we need to do to have clear documentation. Next slide, please. All right, SMART goals. SMART goals are very well-known standards in regards to creating goals and care planning in supporting both in behavioral health and case management and any kind of care plans that are created that are whole person centered. So where do we start? First step is we identify the SDOH barrier, and then we turn it into something very specific and actionable. For example, housing instability, food insecurities, transportation barriers, financial restraints. These are very broad SDOH needs that have been identified during your comprehensive assessments. Your job is now going to be to convert those into goals that can be very realistic. And something you can work towards and then have a defined period of time. And then just to point out why poor goals sometimes fail, common mistakes is we're writing goals that are too vague or sometimes they're very impossible to measure. For example, the client will improve their health. That does not tell us what will change, how we will measure it, or what steps will need to be involved. What interventions are you going to be taking? A real good goal would be, good goals look like they're specific. You have exactly what you're addressing. They're measurable. You're tying them to an actual health outcome or an SDOH barrier that's been identified. So a client will decrease ER visits from 3 in 90 days to 0 in 90 days. That's very short, very straight to the point, but it's also really addressing what it is that you're addressing a health outcome. This really just kind of gives us that baseline of a target, a framework, and a way to really evaluate the progress that you're making with your clients. I will also say that your goals that you're creating with them really also helps ground you in the work that you're doing and really keeps you focused on what you're trying to achieve. And what the work is and it guides your work with that individual. Like I mentioned, we are working with that 1%, very complex, a lot of needs are being addressed, and being very focused on what you're doing and setting those boundaries and setting that guidelines is really important. And your care plan goals is what you create with them. So there's that partnership that you have with your client and what that's going to look like. Next slide. Okay, one other thing, if you've seen in the other sessions that I've been having, is matching your interventions to your SDOH goals, your SMART goals that you're going to be creating. And they have to be skill-based case management efforts. So interventions, how do they show? So as case managers, your role and your skills and your expertise, and no matter what agency you're working at, is you are advocating. You're doing intensive care coordination. With the closed loop referral. Remember, care coordination, it's more of that support and ensuring that you're closing the loop in any referrals that you're making with them. You're doing benefits navigation. This is a big one. You're supporting your clients in understanding what benefits they qualify, what insurance coverage is. How do you navigate? How do you fill out that application? Who can help me do that? Legal supports. That is a crucial part of the skills that case managers bring to the table and their support. The warm handoffs. When you are having a client that is needing behavioral health, county behavioral health services, specialty behavioral health services, you are coordinating to ensure that they make it to that intake appointment. You're coordinating to ensure that they're having the follow-up appointments. You are supporting that client with that warm handoff with that next service that's needing. Housing navigation, again, same thing. You are really connecting them to that service that is needed for them. For housing, you're filling out the applications, you are connecting them to an organization or someone that is going to support them, or you're doing it yourself and helping them with the housing. It really just depends on what role you're playing in those supports. And I think another big one that is really important is that you are coaching and problem solving. You are providing those critical skills. You are supporting that client that might be super overwhelmed and sometimes needs that perspective of what the next steps are going to be for them. And then the appointment support. This is crucial for a lot of them. It's down to the basic details of how are you going to get to your appointment? Do you have transportation barriers? Who's going to pick you up? Do you know how to call to get transportation to pick you up, either from the Alliance? Are you doing Uber or Lyft or paratransit? It's like all these different things is, yes, you are scheduling an appointment, you are supporting, but what are you addressing with your skills and supporting them? When you are documenting, you put in your interventions, you are also showing the effort that you're making in supporting either for ECM or CS. And I will say in documentation, we really want to avoid the non-interventions. These are, I called, the clinic, I scheduled an appointment, or I gave my client a phone number to housing navigation, or I gave them the walk-in schedule for county behavioral health services to go and set up their intake, and then there's no follow-through. There is no plan. There is nothing there that really supports and shows where your expertise as a case manager came in. So I always say use the flow. The SDOH needs equals to your goals, which then at that point kind of drives your interventions that you're going to be implementing for them. Okay, next slide. So, like Darlene mentioned, we have been really talking about the golden thread and how it supports kind of ensuring that we are following the different standards of how you create a care plan, how you support a person, and how do you document all that. So a scenario would be client with housing instability, food insecurity, they're missing appointments. What do you do in these circumstances? One, you are screening. You do your initial SDOH screening to identify what the actual needs and what the actual barriers are coming about. Then you record that. What are your results? What are you seeing? Does your client agree with them? And then what's the plan? Your Z codes. Now you have a screening results. Now you're able to identify which is of the Z codes of SDOH diagnosing you're going to do as a case manager to address. Next is your problem statement. Here is where you're summarizing your client's situation in a very clear, concise way. It reflects the HDOH needs. It incorporates what your client is telling you and what their needs are, and it links the issue to the health impact that we're having here. So how are these barriers, how are these challenging, affecting their overall health? For example, a client's receiving an eviction notice, is running out of food monthly, and is missing appointments due to lack of transportation. That is a clear problem statement that you are identifying when you're working with your clients. So now each SDOH, we're going to prioritize them and then decide with your client's support and talking to them, what is going to be your SMART goals. I will say that SMART goals, you want to keep them broad. You can create a lot of SMART goals, but my rule of thumb is you keep it to 1 or 2. With the level of complexity and services that you're providing, you don't want to overdo it and have a long list of SMART goals because it becomes unrealistic for yourself and for your client. And then your interventions, like I mentioned, those are crucial when you're creating your care plans, when you are starting to justify your medical necessity within your plans. These are your efforts. These are your skilled base supports, your care coordination, and your application help that you're doing, advocacy, warm handoffs. And then your evaluation and follow-ups. This is where you are assessing continuously. Every time you meet with them, you are reviewing these goals and you are seeing where the progress is going, and you're documenting that in your notes. And a lot of those documentation could be still working on it. Okay, next slide. Okay. So here we do want to touch a little bit on the Santa Cruz County SDOH interventions and some examples that come in. And Darlene, I don't know if you want to jump in on this one and just kind of give us a little bit of more information in regards to, because we do have a huge network of resources, and every single organization in this community really has an expertise in working with a variety of different population of focus. I'm going to let Darlene kind of give us a little bit of a walkthrough with a couple of these examples.
Yes. So again, we have great resources in this community, and everyone, even in this meeting, has an opportunity to really highlight the work that they do. So these are just a few examples of concrete, resources. Obviously, there's no way I could have all of them available for you all, but again, one of the things for housing intervention that could be done in Santa Cruz County is complete the HPHP housing navigation referral. And again, you complete it, you're working with the consent of the patient to, support them, in that process. There's New Horizons Shelter, Rebel Shelter, Monarch Services, for DV situations, a warm handoff to our county housing for health or HSC coordination of entry. Again, there's Section 8. We have Project Room Key, cab emergency rental services. These are all just some actual concrete ways that we can support with housing stabilization. And again, there's so many other options, and we're meeting the client where they're at. So whatever that may look like, just suggestions. For food access, navigation, again, completing a CalFresh application, supporting with that. A warm handoff to the Second Harvest Food Bank or one of the distribution sites. It's really accessible for us to look up some of the distribution sites and community partners that have access to that in their own agencies. There's the mobile bike pantry. Going to some of our wellness centers or Meals on Wheels. Those are all great resources. And again, the talking point is in Santa Cruz, there are dozens of food distributions, but ECM's job is to help families actually enroll, schedule, and consistently access these resources in determining it's more than just that closed loop referral. It's supporting them throughout the process, whatever that may look like. For example, if it's a prescription food box, how can we make sure ahead of time that next 12 weeks that is necessary for their success, that documentation is done in a timely manner, and so that there's no gaps in the resource that they're getting. Transportation. Again, there's the Central Coast Alliance for Health transportation line. So I think that one of the things that it's important for us to do is provide them with the resource, but also maybe walk them through it one time so that it's not something foreign to our community members. Of course, we're wanting to support them and not enabling them, but sometimes just the idea of calling is intimidating. So having that first experience is important. Metro passes, if that's available, the lift line, if that's available, identifying, what it is that they need, and also addressing their chronic illness if there is some issues and need additional support. So the talking point would be transportation in Santa Cruz County is often fragmented. ECM support essentially is for coordinating these different resources and to support them with appointment scheduling. I'm recognizing our time. I'm going to go to social isolation interventions because that's one that I did notice a lot of people here were saying was a common SDOH need. There's the Family Resource Center. We have La Manzana as ways to, support. There's also addressing and linking them to our county behavioral health. Senior network kind of would also be great. There's Raíces en Cariños that also have, different resources for our community, supporting them through the Watsonville Parks and Recs, just really encouraging participation in culturally relevant programs. So Mujeres of the community, youth groups, indigenous support circles, those are all very fundamental ways of supporting. And so the talking point really here is social isolation often hides behind transportation issues or caregiving strain or cultural barriers. And so for ECM, we're there to help uncover the root and build real social connections and support them with that process. These are all just some, concrete examples of interventions your team probably already uses. And it's just recognizing the value in that work and those connections and clearly meeting our ECM standards. And I'm going to pass it right back to you, Esmeralda. Next slide.
Thanks. So I did put in the chat, I do want to acknowledge all of you here are experts in the work that you're doing and the organizations that you're working with. And I will encourage everyone to please provide, kind of looking at some of these SDOH needs that we identified, what does your organizations offer? To address these needs. So I will put it out there. I know we have a few people from like PVPSA. I saw some people from the homeless shelters. And so I will encourage that during the presentation if you want to just kind of share that information over. All right. So medical necessity. This one's a big one when it comes to documentation. So I am going to touch on the auditors. All of us that are providing ECM services and recognize we do get audited. Our charts are being audited. The Alliance and Kaiser, if you're working with Kaiser or any health plan and that are providing ECM and funding for the services, do regular audits. So we have to make sure that we are documenting what we consider the medical necessity and be very clear with that. So just quick overview. Auditors are using the golden thread, are looking for a clear how it all ties back together. They want to see an identified SDOH need, a measurable goal, a skill-based intervention, evidence of the follow-up and the progress that you're making. They also check that each part of the documentation logically connects to the next. So you're not having these random documentations where they're not being very clear of why you're having a conversation. So, an example would be if you have a SMART goal, you have your intervention, you're comprehensive, and the goal is that you're doing housing instability. That's what you're focused on. But then on your notes, you go off on talking about, I don't know, their cousin's friend, disclose to you that they're homeless and they want to do, and it has nothing related to what it is that you're addressing the goal. That information is useful in building that relationship with your client, but when you document, you got to make sure that the information you're putting in there is relevant to the goals that you're doing and meeting that medical necessity. The linkage. When we talk about medical necessity, we are talking about the functional impairments or the health risks. That is a big one. When you're interpreting what is it that you are going to identify as the need, is how is this barrier, how is this SDOH need that you have identified during your assessment and your conversations with these clients affecting their health and their functioning level? If after you have done these assessments and it's really not affecting them, their health, there's no functioning, there's no impairments, I'm just going to throw in like depression. A functional impairment is someone that has depression and they're not getting out of bed. They're not taking a shower. They're not doing what they usually would do on a day-to-day basis because of this condition. If you are talking about someone that's not making it to their medical appointments and the barrier is transportation, so you identify transportation, that is something that is affecting their health because they're not making it to their medical appointments, and it's affecting in their function as well because now them not showing up to their medical appointments means they don't have medication refills. It means that now they're using maybe the emergency room as their primary care instead of that preventive care that you would be using. So, examples of these impairments are super important to kind of consider. The poor diabetes control over food insecurities is another one. So just kind of going back to our golden thread is we are going to be linking those SDOH barriers to the health impact that they're having. And then after that, what you do is you're going to really address how you're going to support them with that. How are you meeting that need? So now we're documenting why the services is required, why the need for you to really be there for that person is needed. That is the other part of the medical necessity. identify the challenge, but now how are we going to address it to reduce that impairment or that barrier? So, ECM required situations that you can easily document and justify is the client needs assistance with navigating a complex system. And then you would include in there what that complex system is, because you have to really address what is it that you're addressing. The client has failed previous attempts to solve an issue independently. Again, this is why you're coming in, you're providing that critical skills, that problem solving skills. They require advocacy, case coordination, and multi-agency. Sometimes your work is just being that go-to person that helps them put everybody that is supporting them in the same room, in the same conversation, on the same page. Documentation should really reflect your coordination, your warm handoffs, application assistance, like I mentioned earlier. It demonstrates the service that this is not optional. Without these services of case management that you're offering to them, there's not going to be improvement. This patient continues, or this client continues to struggle. So your statements, I'm just going to put a couple of examples, but for example, a strong medical necessity statement is client's housing instability is causing missed appointments and inability to manage medications. Necessity ECM, needing ECM support to stabilize housing and care coordination. That is a very strong medical necessity. So when you are documenting, you are identifying the problem, but you are also putting it in a statement with that diagnosis that you're going to be submitting when you do your documentation. Another one I would say would be your client's lack of transportation results in gap in specialty care and unmanaged chronic conditions. ECM is required to coordinate transportation and appointment adherence. These statements are really strong because they identify the SDOH need, they describe the health or functioning impairment, they explain why ECM is necessary, and use audit-ready language. What is it that the auditors want to read when they're seeing this? Can move to the next slide. All right, so care planning and quality checklist. So we are going to go more in depth at our next session on care planning and the very specifics, but I do want to take some time to introduce you to the care plans. Most of you are already doing this, but there's this most of a checklist of what you want to make sure you have in these. Quick audit. If you have the alliance or another individual managed care looking at your notes, what are they looking? What is a checklist that you can use? Did you screen? What code did you use? Was it appropriate for what you're documenting? Is the problem statement aligned to your SDOH code, your Z code that you're doing? Do you have a SMART goal? And are your interventions based and tied to that goal? So again, golden thread, we're trying to really tie everything together. Is the client's voice present? Are you indicating what is it that they're saying is their priority? And if any of these are missing, then we have a break in the golden thread, which again affects the ability to really put clear documentation for audit purposes. I'm going to briefly go to the next slide. So I have this case example here, but I'm just, I'll allow you all to read it on this one just for the sake of time. But in Maria's example here, it shows how SDOH issues can cascade. Unstable housing can lead to food insecurity, can lead to missed medical appointments, and to high ED utilization. So we notice how the Z codes and the goals were chosen intentionally to reduce the risk and improve the outcomes here. Reassessments, here we are going to be reassessing every 3 to 6 months, we're going to be demonstrating the progress and provide justification for the ongoing case management improvement. So see, I will kind of address a little bit here. In regards to your plan, for example, for housing instability, the goal would be to obtain housing, rent assistance or transition. And here you're going to be assessing every 6 months. Like I mentioned earlier, your screening tool results, you're going to be documenting your screening tool results, your Z codes. In this case, it would be a Z59 inadequate housing, or you can, once you do assessment, you realize that, you know what, I need to add another Z code because I'm going to do 2 SMART goals. Now you're doing lack of adequate food, and then again, the Z codes, because these are the ones we really want to make sure we're documenting and entering for the billing purposes. And then you're updating your care plans as you need them. And then your interventions, you're tracking them as well. What is the interventions that you're doing for them? And I will move on to the next slide. All right, common pitfalls and things to avoid. Pitfalls typically happen when there's a break in the golden thread in that sequence that we're following to ensure that we're documenting correctly. So SDOH, your screens, but you're not documenting it. You didn't document your screening and your results. You use the Z code, so you build a specific Z code SDOH, but there's no evidence. You don't have the statement there. You're not clearly indicating why you selected that as a diagnosis and what you're going to be working on with your client. And then your interventions, it doesn't match the need. So food insecurities, you're doing work, and then your interventions is I'm going to get them housing, or I'm going to, we're going to apply for housing. Even though those are important, they don't match each other. So you have to make sure that whatever it is that you're putting is as your primary SDOH diagnosis and your documentation purposes, your interventions match that. And then your care plan is overwritten instead of updated. When I say overwritten, I'm saying you create an entire new care plan without justifying the need and the reason. So if you're tracking your care plans, you're doing work around an SDOH need of food insecurity, and then you pivot right of a sudden into housing, and that wasn't something you were doing. Within your documentation, you have to be very clear of why those changes were made and how they were made and what came to that decision. And now create a whole that you're updating, or you're creating a new updated care plan. Avoid these by tying every piece. So some of you having a checkbox, a checklist, making sure that you're kind of touching on all the basic necessities when it comes to documenting. Let's see. And then also we want to be really careful that we're not too vague. And this is an art. Documentation is an art, and it takes time for us to practice. You need to be able, in a very clear, concise way, document something that is not vague and is giving the full picture. So a client needs help with food. That's very vague. That doesn't give us a lot of information. Instead, a client reports running out of food by week 3 despite budget efforts. One sentence, clear, but you are getting all the information that you need and what you're going to be working with. Can go to the next slide. Okay. So kind of building off on the previous slide that we were talking about, documenting the why it matters. The impact on health is crucial. Use frequencies and timeframes when writing your outcomes. Every time you are creating a goal, just have that in mind. What is that timeline going to look like in those outlines? And then the other part is your outcomes and progress. What is it that you are hoping to accomplish with these? So as you're writing them, think about your interventions and think of, is this a realistic goal for both you and your client? And then reassess regularly and document things as they improve, change, or stay the same. I always say if things are the same, there's no progress happening, just make sure you document that when it comes to your goals, because you are still addressing those goals that you have set in your care plans. Be consistent. If you screen it, code it, then make sure it's in your care plan. You have it documented, you have that follow-up. If you're going to do a screening, an SDOH screening at the beginning of your intake, but then the entire time you're seeing this patient, you don't do a reassessment, that's not meeting the requirements because you're not able to assess the progress with those screenings. Some of you will do screenings for substance abuse. Some of you will do screenings like a PHQ-9. Some of you would do that. It is really important that you keep up with those screenings that you are going to be engaging and supporting those clients with. Whichever one you use, just have that in your mind as you're documenting, and when are you going to put those, and then document that clearly when that's going to happen. So an example would be a patient screened positive for transportation barrier. You did an SDOH screening. The note says transportation's a problem, but no care plan entry, no referral, no follow-up is documented. So this fails documentation standards and the coding logic that you would have on there. You're addressing, you're documenting, you're saying this is a need, and there's no backup plan. There's nothing there. Good documentation protects both your organization, protects you, supports the reporting you're doing, and it ensures that you're addressing the client needs so you stay with what it is that you're trying to support them with. And a lot of organizations that are working with, or even yourselves, probably have a template that you followed, something that kind of really helps guide this. So this is something that is crucial and important. Darlene and I will be sharing after the session. We did put some materials together for you in regards to creating SMART goals and so forth. At our next session, we'll be providing additional resources on templates that could be utilized when you're documenting and making sure you're capturing all your data, both in your care plans and in your notes. Next slide, please. Okay, tracking and reassessment. I mentioned a little bit previously on the previous slides about reassessment. Reassessment is required in ECM and for ongoing medical necessity. Regular standard of anytime you bill an insurance, anytime you are working in any capacity with the client where you are managed and you have a payer source for the services you're providing, you have to continue justifying the need for the service and why it's important. So reassessment is crucial. Most insurance agencies have this. ECM in particular, the Alliance requires the reassessments with your clients before they even provide a reauthorization. So just kind of being mindful that those are crucial during the time that you're working with them. And then update your goals. And then close your goals. If you meet a goal, close it out and then work with the client if you're going to do another, if you're trying to work on something else. Or prioritize, shift them if needed. These care plans are considered to be an active document. They are meant to be your guiding source in supporting the clients. The message I want to really point out here is that you can change them, you can update them, you can do what is necessary to really ensure you're meeting your client's need. You just have to be very clear in your documentation why you're pivoting, why you're making the changes, and what is happening, what circumstances are triggering for you to do those changes. Let's see. So let's see, case managers, nope. And then the warm handoffs. This is really important for us to understand as case managers is when are we working within our scope, within our skill level, and when is it appropriate to hand off to another discipline for specific needs that need to be addressed. And this is where leveraging on our community partners is crucial. Maybe as an agency, your expertise is not working with youth. It's not working with children in the child welfare system. But you have that really close partnership with an agency, child welfare systems, or with another partner agency that does have that expertise. This is where you have that partnership, you escalate, and you really support with that coordination and warm handoffs if needed. All right, and next slide. All right, thank you. I think this is, I wanted to just kind of wrap this up. So I do want to just kind of, again, acknowledge how impactful the work that you all do. I know we went over a lot about the logistics, documentation, SMART goals, and we will be sharing this, but at the end of the day, this is people work that we're all doing. This is the work that really supports the health outcome, the impairments. We a lot of times become that go-to for our clients and that leverage, that advocacy, that, you know, we're everything to making sure that their needs are being met, and they come to us. We become almost sometimes as their second family. So just taking that acknowledgement for everything that you all do, and the documentation and it's just part of the work that we have to do. And then just being mindful that this is important as it comes, because this is a way that we really continue supporting by sustaining our programs. our programs are sustained by the fundings resource, so it is really crucial that we are documenting in a way that is helping them, but also acknowledging the work that we're doing because this work is mindful. It is hard, and just want to give everyone a special thank you for that. This takes a lot of dedication, and it's not easy. And I want to check on the slides. Housing Matters addresses homelessness, housing stability. Yep, service navigation workshops on Wednesdays and Fridays for any participants looking for support. Perfect. Is there any questions for us? We have, and Darlene, I don't know if you want to add anything else.
No, just wanted to echo your sentiment, and I'm sure Berenice has interest in finishing with her
Yeah.
survey. So thank you all for all that you do, and I'm looking forward to seeing all of you at our next learning circle, where again we'll be going more into detail on some of the concrete information that was provided here.